Our next speaker is Dr. Hazel Clothier. Hazel's the lead epidemiologist at SafeVic, which is Victoria's Vaccine Safety Service. And Hazel's going to talk to us about respiratory viral epidemiology in a changing world. And this is highly relevant for a number of reasons. Hazel, thank you.
Thank you. He doesn't know, of course, what I'm going to say yet. I would just like to say, if Alan thought it was intimidating following Ian, think what it's like to follow Alan and Ian. And on a similar topic, it's that as well, and my slides have already moved on. So let's go back one. So there we go. The title today being Respiratory Viral Epidemiology in a Changing World. And that title, of course, is open to many interpretations right now. But I will say, I'm going to get the green button working. There we go. This is what I plan to regale you with this evening. I'm going to give you some snapshots of resources that track respiratory viral epidemiology, the factors that are driving the spread and evolution, and interspersed with some case study examples. So nothing about the US. Just putting that in there. So first up, this is a health map, and I love this respiratory information because it is what people are saying about respiratory infections around the globe. It is taken from internet media news and ProMed reports, as we saw Alan putting up, around respiratory illness, and it gives you these alerts. It's not limited to viruses. The dots are showing the intensity of the activity of the conversation, so it's what people are concerned about. There's a broad range of respiratory factors being brought into here, and I've just listed those that affect across our region, which I thought was quite interesting because, you know, we think we're all talking about influenza, etc., but I was quite intrigued that whooping cough was coming up so much. So, the other area I was going to speak to, but I've already had my thunder stolen for me, because as Ian shows that Ian and I hang out in the same places, at least from a data perspective, but the various different sentinel and notifiable and laboratory reporting systems that we have in Australia bring a wealth of information that we can capture through the Australian respiratory surveillance activities and report. But I won't go through those because he already did. But that'll help speed us up whilst you can have your entree. One I would like to settle on, though, this is a bit of a favourite of mine, is this interactive dashboard that comes from the US, and luckily it is still up. It is refreshed weekly, and it shows the routine mapping of 8 respiratory viral infections as test positives from their participating voluntary reporting laboratories. And I'll give you a QR code in case you want to go to it. I'll flick through to drill in so you can see it more clearly. This is showing the last 6 months of what's been going on over in the US, and you can see with does that give me a dot? There we go. With this orange line coming through here, that is SARS-CoV or COVID-19, so it was widely circulating along with the enteroviruses, but as we come in through to, this is a shocker, isn't it? There we go, into right as where we are now in January, influenza is really kicking off over there. What you can also see is where SARS-CoV-2 or COVID-19 is settling at around about 5 to 6% positivity amongst their testing that's done, alongside the other human coronaviruses that are still circulating. And this is really what I wanted to bring forward from this dashboard. It's great for expanding the mindset beyond the big 3 of flu, COVID and RSV, and having the reminder that whilst we have the new interests, the old ones are still around. So the other coronaviruses have been circling for a long time, and if you look last year and also rising up in this year, we have the strain of OC43, which we know through our local data can also cause quite considerable impact in our residential aged care persons. So let's not forget those. And I'm so proud that after 20 years, I can still bring up that paper in a presentation. You don't know how hard I worked to get that one in. However, let's move forward with what we want on factors driving virus spread and evolution. Climate change is such a huge topic. We have the rising temperatures affecting virus transmission and air pollution, wildfires exacerbating the respiratory disease burden. And the complexity of the mechanistic pathways through which climate change influence these viral respiratory infections is shown quite comprehensively in this figure. Could be an entire talk by itself, but I'll leave it there as a useful resource. What I wish to do, let's press the button, is drill it down to 3 main elements. the pathogen emergent through our relationships of host and reservoir, the disease transmission dynamics, and global spread. If we look at these through climate change, it is the shifting of the range of the reservoir species that we're seeing emerge. This is affecting both the transmission and the susceptibility in the disease dynamics and broadening the geographic range of our vectors. We looked a little bit at seasonality. We saw that in some of the earlier slides. This slide up here is showing them from the frequency of which they occurred. There's 18 of them from most frequently detected. This is among children admitted to a paediatric referral hospital, so it's very recently published, very pertinent data for us. This is pre-COVID. And it shows that only 2 were demonstrably not seasonal. That's adenovirus and buccovirus, were marginally so. So we think of respiratory viruses as being our winter or our seasonality, but it's not the case for all of them. And this is what I would like to follow through as we think about how climate change is not as simple as we might think. This Sankey diagram shows how most of the respiratory viral infections can be influenced by at least one of the climatic drivers. And there are regional differences depending on the climate zone in which this is occurring. And the width of the grey belt that's joining them all together represents the quantity of the literature of any given association. So what you can see from this is actually many differences on where you live, what the climatic influence is, what the respiratory pathogen is, but also how little we know about some of these relationships for some of these respiratory viruses. And here comes to my first little vignette or case example. Enterovirus D68 can give mild to severe respiratory infections with some rare neurological complications. First detected in the 1960s, but outbreaks were very rare until 2008, when it is hypothesized that the warmer temperatures were extending the virus's seasonal activity. In 2014, there was intense outbreaks seen in Finland and the US with severe respiratory illness and hospitalizations, particularly amongst the children. That's shown there. So you can see how there wasn't much happening within the center of the circle, but once you hit that sort of 2014 level, you start to see a lot more activity with this virus going around. There seemed to be some interruption due to COVID, but it's been reappearing since 2022, and particularly across Europe. So there's the timing band there for 2021, and you can see that there's new lineages emerging now, quite a lot of activity around, and it's definitely going to be one to watch in 2025, although we haven't had so much in Australia as yet. Of course, we have climate change being strongly implicated in the driving of migration shifts in birds, leading to this increased spread of the influenza, and particularly the H5N1 that we've heard of earlier. I just happen to like the picture in the background of here. But what is going on with birds is not just that it's extending their flight paths. We've heard a couple of theories around the mixings around in the bird flocks that we have of our domestic birds, but the impacts are really varied into the bird host and also the virus ecology at multiple spatial and temporal scales. Far too much for me to go into now, but I think it is very much worth thinking about. These things are not simple, they are very multi-complex. We've seen this figure before as well, in that H5N1 is now a panzootic in mammals. Those that in red were the first time as being host species during this outbreak. One that I'd like to comment on is this is very much is still evolving. There we go. Now, it was such a tease, right? I saw this about cats flick up, about being a transmitter between 2 households, which has not been shown normally in this graph before, but then it's been deleted and I can't find it again. So hopefully in the next couple of days we will. But of course, as we have these spillovers and understand around the different species that can carry the pathogens around, it's going to be very important considering our personal behaviours and particularly our interaction with pets. Another one that I was very pleased to get into the presentation. We've also seen this one before that shows that global spread over a number of decades of the H5N1, with the fortune that Australia being the only continent at the moment which hasn't got H5N1 cases. There was the case that was mentioned of the young person who came through as a traveller. Okay. A slight different topic here, where I couldn't really find an easier way to flow it in, but I would like to also mention around a focal point of climate change and understanding the impact that it might have on vaccines. It's not just the diseases and the interactions there that occur, but if we have such different changes and different outcomes on our ability to control our future respiratory pandemics, we will definitely see a change in our epidemiology as well. The global equity for vaccine prevention around vaccine storage, transportation and stability could become untenable, and delivering safe and effective vaccines is often dependent on that last mile, and there are many changes coming in that space. So thinking further around urbanisation and travel. The increase in population that we are seeing currently is increasing the contact between our reservoir species. The dynamics and contact rates are affecting very much in the disease dynamics as well, particularly with an ageing population. The immunosenescence can be affecting both their susceptibility in the spillover setting as well as in disease dynamics. And the increase in international travel is accelerating the viral spread, particularly the young girl who came through as our H5N1 case in Australia. We have more people travelling, different modes of transport. They're faster, more efficient, carry more people. And this is bringing crowding into our urban centres, creating high-risk environments for outbreaks. I liked this pictorial of what has happened over more than generations. We're talking about the pre-modern and modern times of transmission of pathogens, not specifically respiratory viruses, but nevertheless. In the grey colour, you can see there's very little movement, then goes into the green in the 6th century, where it's mostly around Mediterranean areas with trade and war, moving on to the orangey red colour with the transatlantic slave trade, and then to the purple, which is SARS epidemic, the original one, back in 2003. And I think we can now add cruise ships into that as well. But certainly we are all making a lot more use of travel. It is very normalised. It also spans a lot of age ranges. It's seen as a social interaction for our families, but also our older persons as well are travelling much more comprehensively. Okay, so looking at the urbanisation aspect as well. The projected relative population change from 2010 up to 2100. I find that hard to say, actually, thinking 2100. But this global population is really booming in the billions, that it's going to be bigger. In 2009, we crossed a major demographic milestone. For the first time in history, the majority of the world's population were living in cities rather than towns and countryside. And WHO is predicting that to increase to 68% just by 2050, which we're now faster approaching. So thinking that these urban centres becoming epicentres for outbreaks, we're going to see that more and more so. You'll probably note on here that Australia appears to be spared from the population explosion. I would just like to point out that that is an artefact of the expense of the desert and habitable coastal zoning, and not that we're not going to have a population explosion. So how does that impact then into the respiratory viral pathogens? And we know this now very much as what happens with human mobility changing on what occurs, particularly in our cities. These data are from a Seattle hospital, showing again across 18 respiratory viruses in pre- and post-COVID pandemic years. So you can see the thin lines are showing like the incidence, the darker, broader line is the reproductive rate. And you can see that for some, it's not really changing the reproductive rate at all, but for others, they were shocked into almost non-existent and then had very differing patterns about their re-emergence, often associated with their underlying seasonal patterns as well. So that brings me then to another case study, trying to pick on some different viruses. For human adenovirus 55, it's highly virulent and can cause severe pneumonia. It is a re-emergent pathogen, and it has caused sometimes fatal pneumonia amongst immunocompetent adults, and particularly across in Asia. The epidemics are known to spread rapidly amongst closed populations, first seen in military populations, but it's emerged as a threat in civilian settings, as well as schools and childcare centres. It's currently endemic in China and South Korea, but there's not that much data from other areas to really show where this is going to. but again, it's probably one to have on the watch. It particularly seems to like is rare in pediatric patients, and it does also occur as co-infections, particularly when you're looking at the severe or fatal pneumonias that have been observed. They have very poor prognosis. So as we urbanise, we're going to be bringing our people together. We're more likely to be seeing these cluster and socio-transmitted viruses. But it's not just the people that like to come together, it's also the viruses. So this is excellent data that came out from Queensland, looking at the respiratory samples of children presenting to their paediatric referral hospital pre-COVID, so 0 to 16-year-old adolescents. The adenoviruses are showing very high dual positive count, as I've just said from the previous example. We don't really know what this is going to mean for the virus evolution. The disease severity may change, but also, in particular, the challenges to surveillance, because it's going to be very difficult to tease out what the causative pathogen are if they're occurring together. Another I'd like to just highlight and bring forward as a case example is bocovirus, because over 3/4 of these infections were occurring with others. There's a couple of recent papers that have come out here looking at this being globally distributed. It predominantly affects children, tends to occur with other respiratory viruses, and maybe has a role in superinfections, and perhaps we will be seeing more of those as we go forward with our population growth. So, urbanisation and travel is not all gloom and doom. There is a flip side. The capacity for surveillance and control programs, our prevention and public health knowledge programs are far better in cities where we can come together and work together. The access for people to facilities for treatment and also vaccination is going to be easier. And the global response that we can have, maybe, if everybody is participating in it, the global response and support that we could give, although that is a changing world, would be easier to deliver. So let's also celebrate some of the technological advances that we're having. So to my last main feature here is around zoonotic spillover, and we've seen a lot of that already through the examples, and it's quite largely influenced both by the climate changes of what we need to do to be able to come together and accommodate around the weather things. It's around also the way that we live our lives and around wildlife hunting changing into more intensive farming practices. As I've mentioned about the domestic animals and the way that we all seem to really like pets and varying selections of them and bringing them together. 73% of our emerging diseases are known to be zoonotic in origin. So the One Health programs of work and the intertwining we have with One Health is immense. We really need to start thinking about the animal-human interface that we're developing and the strategies that we can have for managing that. The varied transmission pathways through direct and indirect handling of these animals is also part of what we need to think of our behavioural changes. Now, we've already spoken to influenza and zoonoses, but I loved this paper that I found. We're thinking about our changing on the human and animal interactions. This article is around influenza D virus, and it caught my attention because it primarily affects cattle. It's been detected in various different countries. There's been outbreaks amongst the cows, and there has been a suggestion that there is transmission across to humans with, and I think you mentioned about this, some of the workers, up to 46% in one group of vets had a seroconversion to influenza D. No disease, and I need to make that very clear that there haven't been any human cases, and just because you have serology doesn't mean to say that it's actually an infection for disease. But nevertheless, I loved this comment. From the flu perspective, certainly cows had never really been thought about in studies of spillover. Well, this was written in early 2023, and I think we have a different opinion now, so we're very much in a different and changing world. Here again is some of the work that has been done to look where this influenza D is locating, and you can see that there is a number of animals. There's also travel involved. There is also a couple of human seroconverted cases. Australia, currently still blank. I'd love to know if anybody does the testing out there and what we do know of this virus. And I'm just going to put that up there as a bit of a cliffhanger, because I did as much searching as I could, and I can't find out any more. But if we live in a changing world, then maybe that's what we're going to be facing. My conclusion and takeaway messages. The respiratory viruses are continually evolving. Climate, globalisation and human behaviour are accelerating the spread. Surveillance, vaccine innovation and global coordination are crucial, and we need to prepare for the future of respiratory outbreaks. I want to give credit to, there's a really good map for some solutions of what we might need to do for some of those things from Alan, who sat over there, and also a big plug for global collaborations for the Spit for Science with the Global Vaccine Data Network, which is out in the foyer. If we can bring those two together, we can certainly be working through our conclusions that are on here. And with that, I will take some questions and then let you get on with your evening meal.
Hazel, wonderful talk, thank you. The first question relates to your graphics. Beautiful. Did you do those?
No, I lay no claim to them. They're all referenced at the bottom. I was absolutely fascinated finding all of the wonderful... I think that's one of the developments in publications in recent times. You'll notice most of them are in the last couple of years, and the ability to produce really nice graphics is really strengthening the publications that we see. So yeah, not mine.
This is half tongue-in-cheek, but is escape of a virus from a laboratory another risk?
I was really trying hard to not make this political or controversial. It's a changing world. Although that's happened before, so that's not really changing, is it?
Absolutely. It might just get worse, that's all. Tom?
Thank you so much. I suppose this is tongue-in-cheek as well. You went through all the factors, and climate change, the issue of urbanisation and travel increasing, and the zoonotic spillover, then pathogen emergence dynamics increasing, global spread. But I would put it to you that the real risk isn't any one of those specific factors in and of itself, although clearly it plays a role. It's the alignment of all those factors. Yep. So the power law of all that aligning and the convergence of it is the step too far.
Absolutely, and I think I was fascinated as I was trying to bring in case studies to put into this and share amongst other respiratory viral infections rather than the big three, that it was actually quite hard to think, well, where should I slot that slide? Because it kind of fits with all of it converging together, but it seemed a bit boring if I stuck them all at the end.
Are we doomed?
Well, we do a wonderful job with our vaccines, not just in bringing in new vaccines, the speed that we do them, but the new platforms for easy delivery that can reach broader communities, particularly with maybe needleless ones or the nasal sprays. But the slide from the paper that was just published last year, looking at how all of these convergence of factors can actually impact then on our, what's happening with the storage of those vaccines, and can we get them out there? And if there's flooding, people have still got to carry them physically through floods. So I don't know. And I don't know if we do enough in that space to really think about, if we ruin that opportunity for prevention, then the epidemiology is really going to go wild.
Yeah.
So yeah.
Ed.
Hi Hazel, nice talk. It's amazing. I never thought I'd be hearing about influenza D
I know, I was
at
looking at you.
Immunisation Coalition talk. But just to give a little bit of context, C and D, influenza C is sort of a forgotten child. It really only occurs with young children. Very similar to influenza D. They really only split them apart on, zooming in on the two and looking and see, yeah, sure, there's some difference. All right, we'll call it C and D. But it only affects kids and it doesn't really impact too much in terms of severity. And we don't even look hardly in any labs for influenza C. So good luck finding anybody that's doing anything with influenza D. Maybe that's something for the new ACDC.
It's interesting, isn't it, when papers put out those cliffhanger statements, though, and then you go and you, of course, it's not until you come to places like this that you can actually get the background information as to what's really happening.
So if C's the forgotten child, maybe D's the delinquent.
But
Tom.
cows are definitely not to be.
I don't want to hog the microphone, but I don't think we're doomed. I do think we have to be a bit more creatively imaginative in terms of not just the factors, but how do we stop the convergences?
Right.
A question about, are we going to cry wolf until no one is interested in us claiming there's another pandemic coming? Like, it's got to the stage where the hesitancy and geopolitics and so what, so that it's actually, that's probably going to impede some of our work?
I think that's where I'd get you to turn around and look to all the people that are here in this room, and that's a conversation we should be having here tonight. As an epidemiologist who deals with data, it's like really scary to go into the realm of where you're you're talking about and what we need to do to be able to prevent or act quickly on another pandemic. It's so politically driven as well, isn't it?
Vaccination rates are lowest they've been in Australia.
So Margie's group and comment from Helen as well, those behavioural factors that we also have there on the uptake of the preventions. It's a whole other ballgame.
Hazel, there's a quick online question. If with bovine virus can be spread by milk, can it also be spread by meat?
Going to look to the experts for that.
Does anyone know?
I think the little I've seen on influenza D, it's more respiratory, so it's not going to end up in the milk.
Yep. Yes.
Thanks, Hazel, for sort of rounding off a series of talks. I think you did a great job. I guess when I look at when we start to sort of look at what viruses are circulating, I think you nicely highlighted the difference between adenoviruses and rhinoviruses during the pandemic compared to RSV or flu. Do you think we're really talking about a virome? So some viruses are just as often present in healthy children or adults as people who are sick in hospital, and so we sort of often go to it. That's the test that's positive. That's why this child's sick. And I'm trying to explain to junior clinicians coming through that actually no, that child's not got a high fever because he's got a rhinovirus. That would be on him when he was well or going to daycare without any other problems. So I guess we some viruses we've just learned to live with, and some causes problems. So I think
it'll be fascinating to see how we can work surveillance to be able to tease through that. That's why I really liked that heat map that came out with the dual positive testing. And a lot of those kids were having up to 6 positive respiratory viruses, let alone all the rest of them as well. But, 6. And so which one is causative? And or is it the synergy and super sort of infection of the partnering of viruses that are making them sick? And there's a lot to... I don't think we have the systems in place at the moment to be able to answer some of those questions, but we should.
Shumaz, we were talking about this before the conference. The idea of what's relevant and what's not. Do you have a comment?
I completely agree, and from a clinician point of view, cohorting them in the hospital is now a nightmare because we don't know what to do with the viruses. So I don't know that the multiplexing has actually done us any good at all. We were happy when there was just 2 viruses.
At the back, yes.
Thank you for that. It was really interesting. Particularly around the whole changing world, and as we know, the world is very much changing. And I was just interested to know, there have been increasing conflicts globally, and is there any understanding as to how that may impact viruses and the impact of that?
I think that's one that I'd love to actually segue off and almost do a complete talk on that, because I think it comes into there's the history of what's occurred when there's lots of pandemics that have been triggered around times of military conflict. That's in our history, so I think it's definitely a driving force. But again, the reasons for the people coming together and the way that we maybe do humanitarian aid and think about how you need to centralise to be able to distribute the support, but at the same time you're actually causing a problem, is something we could look at. And secondly, it's around that global response and understanding what preventatives you need to get in so that you can prevent things before they've escalated through those humanitarian and camp environments. We've also seen just recently in our region with Vanuatu having the earthquake, and it was in the news maybe for a couple of days, but I have friends who live and work over there and they're still absolutely devastated, and their health services are in their boots. They are in strife and they're not getting the delivery of their vaccines out to the people who need it. So natural disasters, man-made disasters, that was a bit gloom and doom, but
Hazel, thank you. An absolutely wonderful talk. You've given us
thank you.